Hello, I'm Steven Roy Goodman, host of Higher Education Today. Welcome back to the education program that connects you to contemporary issues, people, and institutions involved in the world of higher education. Today's show is a special joint production of the University of the District of Columbia and the University of Cape Town. I'm here in Cape Town, South Africa, where we'll be talking about infectious diseases. Professor Gary Maartens is a clinician-researcher in infectious diseases at the University of Cape Town. Peter Mehlape is Director of Global Health in Eastern Europe, the Middle East, and Africa for the medical technology company BD. Welcome to both of you.
Thanks. Hi, Steve.
Well, thanks again for coming on. Gary, maybe if we can start with you, can you say a word or two about why it seems like there are always infectious diseases in the world? Why don't they just go away?
Okay, well, I think there are a number of issues. The one is that why are the old ones still around? And the second part of it is why are there new ones coming along all the time? So dealing with the first question, there is no doubt that as people's living standards have improved, a lot of the infectious diseases that used to ravage mankind are dwindling. Most parts of the world are better off than they were a century ago, but there are still some parts of the world where standards of living are very, very poor. But it is definitely true to say that some diseases like leprosy and cholera and even typhoid are decreasing in the world. But I think the view was maybe 30, 40 years ago that most of them would disappear from modern medicine and certainly from countries like the US, and that has not turned out to be the case. Number of reasons for that. Firstly, antibiotic resistance is emerging as a major global problem. Bacteria divide incredibly quickly, so the chances of their developing mutations to develop resistance to antibiotics is very fast. This is evolution in action. And we're beginning to run out of antibiotics, so the ability to control bacterial infections is actually decreasing now, and that increases the facility with which they can spread. When it comes to newer bugs, technology's moved on quite a lot. For instance, stomach ulcers were always thought to be linked to stress and too much spice in your diet or too much acidity in the stomach. But we now know, well, we've known now for about 30 years, that stomach ulcers are actually due to a bacterium infecting the gut of up to 30% of people on the planet. So new technology has allowed us to uncover infectious causes of things that we didn't realize were infectious. And finally, there have been an emergence of new infections in the last few decades. Most of these new infections have actually come from animals. The number of unknown viruses and pathogens, potential pathogens in the animal kingdom is obviously unknown, but it's estimated to be in the hundreds of thousands, if not millions, of potential pathogens that could affect humans. Classic example of that is HIV. HIV is present in very similar form in a large number of primates in Africa. Most African primates have a virus similar to HIV, but they don't get sick from it. They've co-evolved with the virus, and the virus doesn't cause them any harm. But if you take the virus from one monkey and put it into another monkey, that monkey can then develop a sickness similar to what we know as AIDS in humans. And about 100 years ago or so, hunters in Africa who hunt bushmeat from chimpanzees and other primates. We may see them as cute furry animals, but in those countries they're seen as lunch. So when butchering these animals, it's not uncommon for a lot of blood to be spilled around, and occasionally accidents occur. And we know that at a very low level HIV was present in Africa for probably about 50 years or so before it exploded into the epidemic we know today. We've had bird flu in Southeast Asia where humans interact with chickens and poultry, and that's got a high mortality of about 40-50%. Recently in the Middle East there's an outbreak there of a virus which comes to humans via camels. So with human population expanding and contact with especially poultry animals or farm animals increasing, we think that there's going to be more surprises to come in the future, and we just need to be better armed than we were in the past to pick them up quickly.
Well, fair enough. And Peter, how do you interact with some of the research and the work that Gary does?
I think a number of areas. One is education and awareness into sticking to the basics. Most of infections are passing from human to human by hand. Enforcing simple things like, proper washing of hands, can eliminate transmission of infections. That's the one. The second is, as a technology company, looking at technology to try and prevent transmission of some of these infections. For instance, looking at a simple, safe injection. A lot of healthcare workers, doctors, nurses give injections on a daily basis because they're using devices that are unsafe. Often through needle stick injuries or pricks. Infections get spread that way. Even to lay labor in the hospitals. Working on linen, removing refuse and all that. If those devices are not, disposed properly, when they got blood or some sort of, human stuff in them, they tend to spread infections. But by coming up with safety engineered devices, auto-disable syringes and needles, that eliminate an extension of more disposal techniques, just helps a lot in eliminating that. This year in February, WHO has enacted a policy that by year 2020, all countries should have a clear policy in place on proper use of safe injections or injectables, to prevent spread of infections, unnecessary infections. That's the one. That's the second one. The third one is looking at a technology that is readily available to diagnose and test this new infections as they come faster, so that the medical profession can take action quicker. You look at the case of Ebola in Central and West Africa. There was no real clear test or diagnostic test that was really accessible to most of those healthcare centers in that part of the world. I think it's our job to make sure that those technologies are even available at the remote areas, even where there's no electricity, even places where there's no address. People can use solar to operate them, or battery operated technologies.
Well, you both raised some interesting issues here, and the first one that comes to my mind based on what you just raised was the issue of how a student is going to navigate this. There are probably students who would like to work in hospitals. There are students here who would probably like to be involved in the healthcare system in some way. So you're saying that there may be some danger when they're training, right? Because they may be dealing with some things that aren't clean, and they may be coming into contact with some diseases that perhaps they wouldn't have come into contact with if they weren't going to the hospital every day. Is that what I'm hearing correctly?
Yeah, throughout history, going along with the territory of looking after sick people is the cost of picking up diseases from them. In the vast majority of instances, really simple measures, notably washing your hands, protect the healthcare worker. A lot of our research has shown, though, that the spread of drug-resistant bacteria within hospitals, that is actually spread by healthcare workers from patient to patient. And that is a bigger risk than the personal risk to the healthcare worker of picking up an infection. But we do see infections in healthcare workers, and the one that's most difficult for us is tuberculosis. Because tuberculosis, unlike other bacteria or other viruses, can hang around in the atmosphere for days after somebody's coughed. And if you inhale it, you can pick up tuberculosis. And especially in low to middle income countries where tuberculosis is still very common, a lot of healthcare workers get tuberculosis at rates that are 2 to 5 times higher than in the general population. So apart from tuberculosis, most other infectious diseases we can deal with by vaccination, by hand washing, and by simple precautionary measures. But there are one or two, like TB, where we struggle.
But let's take that example of TB. So let's say there are a bunch of people who come to the hospital to get treated for something, and some relatives come to visit that patient. One of those relatives could easily have tuberculosis.
Correct, especially in a setting like ours where tuberculosis is so common and much of the tuberculosis is undiagnosed. People present late or they don't even know they have the disease, they just feel they've got a bit of a cough, and they can be infectious for months or years. But the biggest risk undoubtedly comes from patients themselves. So I don't think that the risk to healthcare workers from relatives is anything more than minuscule. The risk from patients is small, not trivial, but it's small.
And what about medical students? How do, can you, maybe both of you can walk us through in South Africa, because I know how it works in the States, but let's say somebody, a 17-year-old would like to become a nurse or a doctor. What paths would they follow here in South Africa to do that?
The system in the US is somewhat different. People would leave school, go to college, and then go to medical school. Whereas in South Africa, people leave school and would enter medical school straight away. So I think that's a major difference between the US and our system here. Nurses generally go through a training on site. Some of them do degree courses as well, but many of the nurses just join up and get trained on the job. Does that answer your question?
Yes, but my understanding is that in the United States we have a tremendous nursing shortage. Is that not true here?
We have a shortage of both nurses and doctors. And one of the reasons for that is that many of our nurses and doctors go and work in high-income countries like the US. Most African countries, in fact countries outside of Africa as well, low and middle-income countries export a huge number of healthcare workers to rich countries like the US and Canada. And that's a problem for us because the high-income countries are not training enough nurses, and it's much cheaper for them to just recruit nurses who are already trained and offer them salaries which in their home countries are huge and attract them away from where they're most needed. So we don't train enough, but even the few that we do train, too many of them leave. We're trying to address that in a number of ways. We are trying to increase training, but it's costly. It's costly to train nurses and it's costly to train doctors. We are in the process currently of expanding our medical schools and our medical school numbers, but it's a slow process. The pool of people who can train is finite, and although we're a biggish country, there's only so much that we can do to alleviate the problem.
Just some challenges related to that is, I think, Gary's right. There's a lot of effort put into that. Some collaboration between private sector and public sector in trying to address this big gap. I mean, we know the country needs an X number of doctors and nurses, but the production of doctors and nurses, it's like a factory, and the market demand out there. The market demand thousands. You're producing 1,000. You have to first deal with the capacity at universities to produce more. And once that is done, there's the challenge that Gary mentioned that South Africa trains highly qualified nurses and doctors who are sought after in the Middle East, in most of English-speaking Europe and the US, and even Australia and New Zealand. So, and to control that, it's a big challenge because if I'm a good professor that is sought after everywhere, that choice is at a personal level, to stay. The one other thing is often doctors, nurses are not always available where they need it. For instance, in rural areas where the need it's high, but for personal reasons, people will choose to be where amenities and life is just much better. But I know that people Gary are doing a lot of outreach work into the Eastern Cape and all that to try and address that, you know. So there's been a lot of interventions at different levels. I know interministerial level where, you know, our Minister of Health and the UK and other places, they've kind of agreed and say, don't touch our doctors, don't touch our nurses. But it's at a personal level. If I want to leave, you know, I'll find a reason to leave, you know. But the solution is probably looking into producing enough to supply what you need as a country. Even the US need to produce enough what they need, as opposed to taking from other countries.
Well, I can't speak to South Africa, but I know the issue in the United States is somewhat similar to what you're raising, because all the doctors, or many of the doctors, want to be in the big cities, and there's a tremendous need in the rural areas. But the other day, we did a taping right here in this studio with one of your colleagues from Cape Town, who argued that traditional healers have a role in the medical world, in that people in South Africa ought to take traditional healers somewhat more seriously than perhaps they are taken now in certain Western ways of thinking. Do either of you have a thought or two about that?
Yeah, it's an extremely complex issue. There is no doubt that the majority of our population at some time or another will consult traditional healers. And that's not unique to South Africa. It's a very strong feature of life in Asia. And I would argue that homeopathy and naturopathy and chiropractor and all of these other alternative forms of medicine in the West are really just very similar to traditional healers, I think. The problems with engagement with traditional healers are multiple. First of all, what is a traditional healer? It may vary from somebody who dreams a solution to your problem, or somebody who practices witchcraft, or somebody who gives you herbal remedies. So there are so many different types of traditional healers. The second issue is that they're not organized into groups that one can easily engage with. So it's challenging. But we have tried to address it, and a number of medical schools have had outreach programs to try and reach groups of traditional healers. Some work has been done in this country to look at the herbs used in traditional medicine, and our group at Clinical Pharmacology in UCT was actively involved in this for some years, trying to find new drugs from herbal remedies. And we've had a few interesting hits of new compounds, but nothing too dramatic as yet, although now we do finally have one of these compounds was extracted and then worked on by clever chemists, and looks like it might be quite a promising drug for malaria. So yes, it's important, but it's very complex and difficult to engage with such a diverse group of traditional healers, and there's a lot of mistrust on both sides. We do different things, we see things differently.
Fair enough. Peter, do you have a thought or two about that?
Yeah, I mean, I've been very fortunate to work across the African continent and travel across Eastern Europe and also the Middle East. It's, I think Gary's right. You know, it's very complex. It's about standards. You know, if you go to a traditional healer in Ouagadougou or to Nairobi or Kisumu or Dar es Salaam, you're going to get, you know, the brief being the same thing, you're going to get different things. And in a lot of cases, not so helpful. And that does not take away the demand and the need and the place for them in the society. But without those, you know, simplification and standards of, you know, what they're really doing, it's just not taking that profession too far, you know.
Well, I had a follow-up question about the cost of medicine, because my understanding is that it takes a lot of effort to develop certain drugs, like HIV drugs. They're expensive. Mm-hmm. But how do poor people get that medicine?
I think HIV drugs are a very good example. The current model is that the giant pharmaceutical companies are the only companies that are big enough to develop a drug. Most drugs that are promising fall away for various reasons, and only a small percentage actually make it into clinical trials. And clinical trials cost in excess of $100 million, and quite a lot of them fail. So you need a big company to develop and generate new compounds. And clearly, one thing that you need to give back to that company is a decent profit for a period of time so that they can continue to do that. I think nobody would argue that that is the current model for the world, and largely it seems to work. However, there are a number of complex issues. The first thing is the magnitude of the profit margins of many of these companies is extremely high. And you can judge that by looking at the performance of the companies themselves. They outperform most other commercial companies. Secondly, it's quite difficult to get from the companies themselves how much of their profit is plowed back into R&D, because until very recently the R&D and the marketing were mixed up, but we now know that most of it's going on marketing, not as much being plowed back into R&D. But finally, we need to recognize that when there are global emergencies like HIV, it was absolutely outrageous 10, 15 years ago. The drugs for antiretrovirals, they're called antiretrovirals because HIV is called a retrovirus, and that's because it inserts its genetic code in a mirror image, making it backwards. That's why we call it retrovirus, and then it goes into the human cells. So the drugs for HIV are called antiretrovirals. These antiretrovirals, still in the USA today, cost thousands of dollars a year. They were completely unaffordable. So I was sitting in my clinic watching all of my public sector patients slowly die when I knew there was great therapy around which could make people survive for decades. I was able through clinical trials to access a couple of hundred of my patients, but the vast majority of them simply died. And HIV was the first disease where there was a confrontation between civil society and the companies. And they agreed, after some wrangling, to provide the drugs at access pricing. And that's made a huge difference. The life expectancy in South Africa has increased from under 40 to over 60 in a very short space of time. These drugs are absolutely fantastic. And I think what's wrong with the current model is that HIV was an exception, but that should apply to other drugs too. You can't generate a drug for hepatitis C, which is common in the US now. There's some fantastic new drugs. They cost tens of thousands of dollars a month, and that's not fair. You can't expect countries in Asia and Africa to afford that. So I'd like to see that extended. And by the way, with our huge antiretroviral program we have in this country, the price we pay for antiretrovirals that you pay for in the States, we charge about 5% of what you would be charged in the US. And the companies are still making a profit, even though we are paying 5% of what you pay. So that just gives you an idea of the scale of the profit. So the global view of this is changing, but in my view it's not fast enough. HIV blazed the trail, but we haven't had much follow-up, and I'd like to see more of that happening, so that new benefits come along to developing countries earlier. Because typically a sole patent on a new compound would be there for about 15 years. And we would generally have to wait 15 years before the generics come along, which are identical molecules produced by other companies at cheaper prices. Then competition comes in, and then the prices spiral down very quickly. So we usually have to wait 15 plus years. And I don't think that that's fair.
I think Gary's right. That picture is changing. Maybe the problem is the pace of that change. I think, as a technology company, BD embraced that in a big way, and from a long time, through many tweak and changes of business model. You read my title as being a global health director. So looking at exactly, how can we increase access to healthcare? How can we be part of the solution, not part of the problem? Through social investing, through partnering for new product development, that are not even our core business. But looking at you look at the new SDGs or Millennium Development Goals that are set now. Areas I think that are very much relevant to our strength, to our expertise, has been Millennium Development Goal 3 and 4. Looking at that still mothers and children, maternal and newborn, they still die unnecessarily. In that way, accelerated some of the products that are not even part of our core. And of course, you're right, we hit some stumbling block. If we take that business model through our channels in the company, it's often hit with difficult questions, in terms of saying, how relevant is this to what we do and who's going to finance it? Because to bring, like Gary mentioned, to bring in a new product from the very beginning to the end, it costs a lot of money and you're not even sure you're going to get it back. So it's, you have to be sure of what you're doing. So about last month, I actually spoke here in this town at the World Economic Forum for Africa about the new innovative way of funding product lines for unmet medical needs, looking at a blended financing, where we got some private sector funding, we put our own money, and got some public sector funding. Bill Gates Foundation and the Norway put the money on one of the product that we do. I think you should Google it, called Odon, a product that is not core to us, but is needed out there. We, used our strength in terms of research and new product development, and the ability to commercialize products and through partnerships and bring that product to market. In fact, that concept of blended financing is actually gaining momentum. I think next week there's also a big meeting in Addis to look at how to leverage that, not just into the medical fraternity, but look into how do you also improve infrastructure. Because if you look at airports across the continent, roads and rail need a lot of investment, to improve healthcare, education, and everything else. But the funding, the blending of bringing that, need a new business model, a rethink in terms of who's going to pay for it, and not wanting to get paid back in break even in 2 years, but maybe look at 15 years.
Well, fair enough. Thank you both. If you would like additional information about Gary Maartens or Peter Mehlape, please visit clinparm.uct.ac.za or bd.com. If you have comments or suggestions about higher education today, please send an email to our viewer mailbox at highereducationtoday@topcolleges.com. Thank you for watching. We will continue to bring you quality discussions about important matters in today's college and university world. Please join me again for another edition of Higher Education Today. I'm Steven Roy Goodman, and you've been watching Higher Education Today.